Hello, everybody. I'm Aaron Ritter. I'm the fellow that works here at the Brain Center. I've done 4 years of residency. Now I'm doing the second year of my fellowship. So a fellow just means you're still a resident, but you don't have to stay overnight in the hospital as much. At some point, it's going to end. But at some point, I don't know when. July, I guess, is what they're telling me. So I'm going to talk about mild cognitive impairment. This is kind of a new created category that we've only kind of thought about for probably the last 30 years or so. And it kind of came out of the Mayo Clinic in Minnesota. There's a neurologist by the name of Ronald Peterson. It was his idea to come up with this idea of we have patients that have dementia, we have patients that have normal cognition, but there's this whole group of people that are kind of in between, are not demented, they don't live in nursing homes, they live in the community, they do all the things that typically we need to do to get through the day, but they're not doing them as well as they used to, and typically because of problems with memory, but can be other problems with cognition. So we've actually sort of created this whole cohort of patients that we call mild cognitive impairment. So we've kind of come up with these requirements about how to characterize somebody as having mild cognitive impairment. And the main requirement is mild problems, having difficulty, but not unable to do something, but having some mild difficulty in paying bills or preparing a meal or shopping. Things are just taking a little bit longer. The bills aren't being paid as efficiently, perhaps missing a couple bills, but overall the person is still able to kind of do all the what we call instrumental activities of daily living, the things we need to do to live independently. The second requirement is that the patient's not demented, meaning the demented person has difficulties with cognition to the point that they can't live independently. So it's a fine line often between having mild cognitive impairment and dementia. And then the impairment has to be due to problems with the cognitive domains. We're going to talk a little bit more about what I mean by cognitive domains. But it's a problem in memory, attention, what we call visual, spatial, learning, executive functioning. We'll talk a little bit more about that. And this is not normal aging. So the people that are in this cohort of complaints have memory problems that are a little bit more than what we consider typical normal aging. And how we determine between normal aging and this mild cognitive impairment cohort is a little bit controversial. And that's something that's always been kind of difficult to determine. What's normal aging and when do you cross the threshold to be in this mild cognitive impairment group? Often get the question, is it Alzheimer's or is it dementia? That's a common question we see in the clinic. So dementia is a description of a person's functional abilities. So a person that is demented cannot live independently in the community. That's for a variety of reasons, because they can't pay the bills, because they can't take care of their medicines, because they can't provide their own food, water, or shelter. So that's dementia. When saying somebody has dementia doesn't tell you what the cause is. There's a bunch of different causes of dementia. Traumatic brain injury is the cause of dementia. Stroke disease can be a cause of dementia. Things like Lewy body disease, frontal temporal dementia, these are all causes of dementia. Alzheimer's disease is by far the most common cause of dementia. But a person with Alzheimer's disease doesn't necessarily have to have dementia to have Alzheimer's disease. So we're starting to see that people with this mild cognitive impairment also can have Alzheimer's disease. So Alzheimer's disease is causing the mild cognitive impairment, but it's not to the point that it's causing the person to be functionally unable to live on their own. And then one of the things to say, what's the difference between normal aging and what's kind of going to the category where a person would be in the mild cognitive impairment? And that's always kind of been a bone of contention, but typically forgetting names and difficulty with multitasking are not abnormal for normal aging. So those problems with having more difficulty remembering people's names and multitasking are thought to kind of decline over time with normal aging. It's not necessarily a sign that a person has mild cognitive impairment or is going to develop dementia. Cognitive domains. So this is one of the criteria for diagnosing someone with mild cognitive impairment, is having a difficulty in one of these 4 core cognitive domains. So if we look at that picture of the computer and sort of the, I guess what you said, the mainframe, our brain is a little bit, we're starting to find out our brain is organized a little bit like this picture, in the sense that different parts of the brain and different networks are devoted to different activities that all kind of work together to the overall functioning of our brain. So we have a part of the brain that's devoted to recent memory. We'll go into each of these a little bit more. We have a part of the brain that's devoted to language. We have a part of the brain that's devoted to visual spatial negotiating. So in visual spatial, it's a little bit like seeing things in space and how they relate to each other, knowing how much, to reach for the controller, how far away that is. I mean, that's a very complicated process that the brain is constantly doing at all times to coordinate all this activity that we do. And then executive functioning. Executive functioning is kind of a little bit of the thing that kind of differentiates us from animals. It's the central processor. It's how we control our sort of more basic instincts. Why we get up in the morning. So that's the executive functioning part of the brain. That's sort of the complicated part of the brain that tells the body what to do. So our brain is kind of organized into each of these different networks. And with the neurodegenerative diseases that we see, typically a protein or something abnormal happens in one of these networks and causes a problem with each of the domains, kind of individually, in an isolated form. So in Alzheimer's disease, recent memory is the cognitive domain that seems to be most susceptible to the buildup of that amyloid protein. So often in typical Alzheimer's disease, we see problems with recent memory first before we start to see problems with the other cognitive domains. So we are able to kind of see how the brain is a little bit organized. This is a statistical representation of how our brain is organized. So this is the concept of sort of the network, that the brain is organized into these discrete networks, and we're starting to be able to identify functioning in each of these different networks. So we're just scratching the surface about how the brain functions. We're starting to see that with statistics and math, we can kind of start to unpack some of the organization of the brain. I always tell patients that our understanding of the brain is probably about 100 to 200 years behind what we understand about the heart and the liver and the lungs and these other organs in our body that are relatively easy to kind of understand. In the brain, we're about 200 years behind. So think about it. We're like about the 1800s in terms of where they were with cardiology. It's astounding how far we are behind in terms of understanding how the brain works. But we're making incredible advances in the last 30 years or so. But we're starting to see that the brain is really organized into these discrete networks. So the most important domain, cognitive domain that we look at here at the Brain Center is the domain of recent memory. So there's a specific part of the brain that is devoted to forming memories, so forming new memories. And that's the hippocampus and the limbic structures of the brain. And then we have a little picture of it right there. So the hippocampus and the limbic structures of the brain, so the parts of the brain that are devoted to the recent memory are what we consider phylogenetically older parts of the brain. So from evolution, they seem to be more of the basic part of the brain. The cell structure and the layers are a little bit more basic. That seems to be why they're so susceptible to Alzheimer's disease. In Alzheimer's disease, the Alzheimer's disease protein starts to build up in this part of the brain that's devoted to forming memories. So people with Alzheimer's disease generally don't have problems with their old memories that have already been stored in a different part of the brain, but it's forming new memories. So things like, what did you do yesterday? What the conversation I just had 5 minutes ago? So that's important because this is a sort of the domain that we can identify with testing, neuropsychological testing, give us a better sense of what's going on with that cognitive domain. The picture on the bottom gives us a sense of kind of how the brain is changing through these different stages. So this patient, this is kind of a representation of what that part of the brain looks like at different stages. So in a normal 75-year-old, we can see that the circled area called the hippocampus seems relatively preserved. And as the disease sort of progresses, there's more and more shrinkage of that part of the brain. So we can actually identify this with neuroimaging.
With what?
Neuroimaging, so MRI, a picture of the brain. That's actually an MRI of the brain. So that's the recent memory part of the brain. The language part of the brain is actually in a different part, housed in a different part of the brain called the temporal lobe. So that's kind of on the outside of the brain. And the language is a very complicated activity, but it requires a kind of a different part of the brain, an integration from different parts of the brain. But really it's stored in that outside part of the brain. That part of the brain is particularly susceptible to having a stroke. So a lot of times when people have a stroke, they'll have aphasia, which means that they can't really come up with the words that they want to say. They know what they want to say, but that part of the brain, if it has a stroke in that front part, right there, that purple area, it's Broca's area, the language is, the function of the language part of the brain doesn't work, and the patient can't express themselves. It's very frustrating. So that's the language part of the brain. The way we ask about the language, how to assess language, is we ask people to write sentences, we ask people to name things, we ask them to come up with words. I had a patient, and this part of the brain can be susceptible to neurodegenerative disease as well. That language part, that language network can get disrupted by disease as well. So I had a patient that I asked had a sentence that I wanted him to write: "The sun rises in the east." And he had sort of early language parts, and this is actually what he wrote: "Sun rises in the east." So there's starting to be some language problems. We often will have problems with naming, so we show people pictures of different objects, and a person that's starting to have language problems won't be able to name things that are kind of difficult to remember, like igloo. So it's the language part of the brain. This is a picture of somebody that's had a disruption in that network part of the brain, the language part of the brain, and you can see that the temporal lobe, sort of the outside. Does this have Jasmine, does this have a pointer on it? I can just point to it. So this is the temporal lobe of the brain. Right here you can see it's the actual lobe itself. This part is actually shrunk itself. So this part is really shrunk compared to this is a normal brain. You can see how thick and more plump it is. Wow. So this patient would probably have similar difficulties in sort of naming, coming up with the right words and things. So this is the language domain. And as you can see, the rest of the brain actually looks pretty good. It's really kind of just in that language part of the brain that we're seeing. So it's that network that's been, it's like a hacker has almost got into that network and caused problems with language. I talked a little bit about visual spatial. This is a different part. The brain is, a different part of the brain is occupied with doing visual spatial functioning. So also on the outside, but it's more of a diffuse throughout the brain. So it involves different parts of the brain. We can pick that up by having somebody draw sort of a complicated object like this cube. So the cube is a three-dimensional shape, and people with visual spatial difficulties can't really figure out how to draw the lines to make it make sense. So we think that's an indication of a visual spatial dysfunction. So that person draws a very flattened cube. So that can be affected in different diseases that we see. Executive functioning is primarily done by the front part of our brain. The difference between us and animals is we have this big frontal lobe that takes up almost the whole brain itself. I mean, you see that kind of the pink color. The front part of the brain is devoted to is kind of the executor. It's kind of the CEO of our body, and that part of the brain tells us, controls the rest of the brain, but it kind of problem solving, decision making, keeping things sequenced and organized. That part of the brain is the executive functioner. So that's another domain, cognitive domain, that can be affected. In a disease called frontal temporal dementia, we have shrinkage of just this network, so the front part of the brain, so we call it frontal temporal dementia, so they have frontal degeneration. And these patients have a lot of difficulty with controlling their behaviors, with sequencing different things, with finding out how things make sense. So that's a disease affecting the network that is involved in executive functioning. So this is a common task we'll assess in the clinic, and it's called the TRAILS test. And basically the task is for the patient to connect alternating numbers and letters in a sequential order. So the pattern would be to actually, with your pen, to connect 1 to A to 2, 2 to B, B to 3, 3 to C, C to 4. So we're alternating numbers and letters. A patient that's had problems with executive functioning, they can't keep the rules of the game straight in their head. They can't see to go back and forth. So in this patient, went from the 2, he saw the 3, and he said, oh, of course, this is where I have to go to the 3, because that's sort of the stimulus, and he doesn't have that executive functioning to keep the rules of the game in check. So that's a different cognitive domain of the brain that the brain is devoted to. So that's what we're talking about in cognitive domains. So this is a scan of a person with frontal temporal dementia, and you can see if we cover up the front part of the brain, looks pretty normal. If we cover up the back part of the brain, we can see that that's not very normal. This is a normal to compare to. So we see that there's a lot of shrinkage of this, the front part of the brain, just by itself. And that's what we see in frontal temporal dementia, another form of dementia. So that's the hacker getting into that frontal executive part of the brain. This is caused by a buildup of a protein in that part of the brain.
Is that amyloid?
It's not amyloid. It's a different one. It's called tau. This is a tauopathy, T-A-U. So it's a different type of protein. So when we think about patients with MCI, we said that they have to have a problem with one of the domains. So we can actually do with our neuropsychologists, we'll actually test with different tests, can actually separate out different domains, and they do it with different kinds of tests that are designed to test different parts of the brain. So we have tests of memory, we have tests of executive function, we have tests of language, and they'll actually spit out a report telling us where there's been problems with the performance on a different part of the test. So this patient had difficulties with performance across a number of domains. The line is kind of the dividing line between normal and abnormal. So a patient like this would have problems with both memory and executive function. I think the language is normal. So this helps us understand how the brain is working, how those different domains are kind of working together. So there's different types of MCI. There's the kind of memory predominant MCI, people that are kind of forgetful. There's the non-amnestic MCI, people that have problems with their cognition, one of those cognitive domains, but it's not necessarily the memory. And then there's patients that can have problems with a bunch of different cognitive domains at once. We can go.
What's MCI?
So it's mild cognitive impairment.
Oh, thanks.
That's this kind of group before, not normal, not demented, but kind of in the middle between the two.
Thanks.
Sure.
What's a sample of the non?
Pardon?
What is a sample of the non? The second one.
The second one? So they would have normal, for example, if the performance on the learning, recall, and recognition, those are all memory tasks, if their X's were above the line. So they could have problems with maybe just that executive functioning, the rules of the game part, or they could have problems with just language. So that patient we looked at that had the language part of the brain that was affected, they might have normal memory, but just have language problems. That would be a non-amnestic MCI person. The question is, how many people have MCI? How many people kind of fall into this category of not being normal but not being demented? No one knows for sure, but We think in older populations, people above 70, that the prevalence is a lot higher than 15% of the total population, and it's a lot more common in men than females. So we have no idea why that's the case. But in this sample, up to about 40% of males had problems with their memory. They weren't demented, but they had problems with their memory when they were in the 80s. So this kind of problems with memory is very common as we get a little bit older. So it affects a lot of people. The amnestic, or the forgetting MCI, the person that has mild problems with their memory but seems to do everything else pretty good, is the most common type. It's about twice as common as the non-amnestic MCI. And it seems to be a lot more common in males that have problems with memory in one of the cognitive domains than in females. Risk factors for developing MCI seem to be kind of vascular risk factors, so hypertension, diabetes, obesity, heart disease, and stroke are risk factors for starting to develop memory problems. So why are we capturing these people? Why do we create this diagnostic criteria for these folks? Is because the idea is that we want to identify these people early, one, so we can start to potentially do treatments that prevent them from progressing to dementia. One is to sort of give a prognosis about, well, I'm starting to have some memory problems. Does this mean, is it going to become a bigger problem? Is it going to stay the same? Is it going to get worse? So we want to identify these people that are having memory problems. And the studies seem to indicate that people with starting to have memory problems that kind of fit into this criteria are at higher risk for eventually going on to develop dementia. And it's usually within 3 to 5 years is most of the studies indicate that the risk is kind of within 3 to 5 years that about 10% a year will go on to develop dementia. But we're also finding that even people with MCI, up to 40% of people with this MCI with some memory problems, some impact on their functioning, actually don't get worse, either stay the same or go back to normal. So that's the other thing we're starting to see about people with memory problems. It's not necessarily a sentence that you're going to go on to develop dementia. So we're starting to learn so much more about this group of patients. So it's not necessarily, it is a risk factor, but it's not necessarily an absolute risk factor for developing dementia. A lot of things can cause people to kind of fit into this criteria of MCI. Well, neurodegenerative disease is the most common. That's about 50% of people. So when I say neurodegenerative disease, I'm mostly talking about Alzheimer's disease, but I'm also talking about frontal temporal dementia, Parkinson's disease, diseases that cause the brain cells to actually degenerate. Stroke disease is a common cause of MCI. But we also know that things like problems with mood and psychiatric problems like anxiety can cause problems with memory and cause problems with one of the cognitive domains. Medications are a common cause of people fitting into this MCI category. And the most common culprits are things like Benadryl that are anticholinergic, so they block the acetylcholine receptors. Pain medicines like Vicodin and hydrocodone and MS-Contin, they cause memory problems. Benzodiazepines like clonazepam and Xanax can cause memory problems. And sometimes sleeping aids like Ambien can cause people to have memory problems that look a lot like neurodegenerative, like a person's having neurodegenerative disease, so medications. So a big list of things that cause people to have problems with their memory. Poor sleep is another one. So things like obstructive sleep apnea, people that are sleeping at night thinking they're getting a good night's sleep, but they're not getting enough oxygen. It's almost like they're drowning all night, gasping and choking. If your brain is not getting good sleep, it can dysfunction. People that have shift work sleep disorder, so the folks that work the swing and the overnight shifts can sometimes have memory problems that are related to the lack of sleep. And then folks that are getting inadequate sleep. And then sedentary lifestyle, I think, is a risk factor for MCI as well, not being active. So who do we think are the folks in the MCI that are at risk for going on to develop dementia? And what are the risk factors if you have MCI for going on to develop dementia? And it seems to be age is the biggest one. The older you are when you get MCI, the more likely you are to develop dementia. The likelier you are to progress to developing, that the memory problems are going to get worse. And it's very unlikely. So people less than 50 that have MCI, that have memory problems, it's very unlikely that they will go on to develop dementia in the near future. So if you're less than 50 and you fit into this criteria, it's most likely that you'll go back to normal or stay the same, will not necessarily progress unless there's a strong family history of having early onset Alzheimer's disease. The severity of the cognitive deficit is also a risk factor for progressing from mild cognitive impairment to dementia. Depression seems to be a risk factor for having MCI and getting worse to developing dementia. Genetics, heart disease, and then certain findings on MRI, on our neuroimaging, the pictures we take of the brain, certain things that we can sort of see on the brain scan that will tell us that a person with MCI is likely to get worse. So what can we do about, you've been given it nothing. Yeah, thank you. Well, there's no current proven pharmacological treatments for MCI. So we've grabbed these patients and we've tested them with the medicines we use for Alzheimer's disease, and they don't seem to make cognition all that much better, and they don't seem to prevent people from progressing to develop dementia. We often try them because they think that they might improve symptoms, specifically memory or attention. Some of the Alzheimer's disease medicines sometimes help folks with memory and attention. Because this is such a big percentage of the population, we've done a lot of studies with a lot of different things like vitamin B, statins, vitamin E, and there's kind of mixed data on all of those pharmacological treatments. This is a big marketing, well actually this is a medical food called Axona. Axona is essentially coconut oil, so it's a medium chain triglyceride. The idea is that if you take coconut oil, it seems to be an additional source of energy for the brain. Even though it's a medical food that's approved by the FDA, it hasn't been shown to be efficacious. So we don't have any evidence that this really does help people's cognition in our tests, in our clinical trials. This is always an option though, because theoretically it sounds like an additional source of energy for the brain may be helpful, but it just hasn't been proven with studies, large studies.
Does one need a prescription for Axona, or is that available?
No, it's a medical food. It's over the counter. So this is Prevagen. Prevagen is a marketed supplement, so it's not an FDA-approved medicine, and I guess the idea is that there's this ingredient that they isolated from jellyfish called apoaquarin. Would potentially boost memory, but there's not been any studies that have shown that it's been beneficial. So the company itself says that they've had studies, but they haven't released them to the public. The FDA is actually investigating claims against them because they've made a lot of money. I think the company has made $16 million in the past year. They just don't have the evidence. And there's some evidence to suggest that the active ingredient in Prevagen is actually broken down in your stomach, so you're not really getting anything from the treatment. So I'm really hesitant to recommend any of these marketed treatments that don't have the evidence behind them. But I think there's very strong evidence that exercise is the best treatment for people with MCI, mild cognitive impairment. And we have three studies that are observational in nature. So observational meaning we study people, we ask them what they did, and these are 3 large studies, and they all seem to indicate that exercise seemed to help people's cognitive function that had memory problems. So the Nurses' Health Study, self-report of being more active was associated with better performance on cognitive testing. So the evidence that's kind of a lower form of evidence, but it was replicated in the Honolulu aging study. There's an error here. I think
Yeah.
I apologize.
But
It's
you
a
want
big
to throw
difference.
out your research.
Yeah, right. So the men. This is all folks that lived. These are all Hawaiian men that they followed for a number of years, and they followed them all the way to autopsy. The folks that walked 2 miles a day had a 2-fold less risk of developing dementia. So these guys that did just walking seem to have a less risk, 2 times less risk. Sorry about that. And then there was a large European study.
What is it when you forget certain words?
Good point.
Sun rises.
The sun rises in the east. And then this European study, risk of cognitive decline doubles in those with the lowest amount of exercise. So there's some observational data. It's not all that strong. And then 2008 JAMA, which is the Journal of American Medical Association, so one of the most respected medical journals, did a randomized controlled study. So this is our strongest form of evidence. They enrolled 311 people. This was done in Australia. Folks were older than 50, and they had to have some sort of memory problem. So they broke the folks into 2 different groups. One group was selected to do a home-based exercise program. So the threshold was 150 minutes a week, and most people did it by doing 50 minutes of exercise 3 times a week. And it was just generally either strength training or walking. Most people did walking. And then the other group they just randomized into not doing the exercise program. They were followed for 2 years. And as early as 6 months, the patients that were in the active treatment group had increased performance on memory testing, and then the benefit was seen for up to 2 years of the entire trial. So this is fairly strong evidence from a randomized controlled trial that the folks that did exercise, and we're talking 150 minutes a week of walking or strength training, had benefits in cognition that were realized for up to 2 years. And they separated from the other group that was not in the exercise program. So the theoretical benefits of exercise in the brain have been proven pretty definitively in animal studies. So we put, how they do this is they put rats in that have one of those wheels, and they have rats that don't have an exercise wheel, and they have them exercise a certain amount of time during the day. Then they sacrifice the rats, and they look at different parts of the brain. So the rats that exercise had improved blood flow to the memory centers of the brain. They also had increased what we call growth factors for neurons. So they showed more strong nerve growth in the hippocampus, the important parts of the brain that are forming new memories. So let's see. The hippocampus is the middle part that's devoted to the memory center of the brain. And why that's important is because in Alzheimer's disease, we lose cells, we lose the structure and the integrity of the brain. So anything that could regrow cells, that can regrow neurons, is crucial for Alzheimer's disease, because the idea at this point is once that part of the brain is gone, it's gone. So the fact that we've shown from exercise in animal studies that we can regrow parts of the brain, that's a very powerful finding that we encourage people that exercise is so important. So the other thing that is starting to accumulate evidence behind it is these cognitive engagement or cognitive enhancement, things like Luminosity and those other programs. The Luminosity program was developed by some neuroscientists, and they've been collecting a lot of data. So far, the data doesn't seem to indicate that those specific types of programs are superior to another type of program, and Luminosity is actually quite expensive. But some sort of cognitive engagement seems to be good for improving cognitive performance in people with MCI. And the most studies have shown it doesn't matter exactly what it is. It's any sort of cognitive engagement. It's reading, it's doing puzzles. It doesn't. Right now, the data is not suggesting that one form of cognitive engagement is better than the other. it does suggest that watching TV all day or not being active is not. So this is I'm kind of the end of the slides here. So I think in summary, mild cognitive impairment is a description of a person with some difficulties with their cognition, and one of those domains that we talked about, memory, visual, spatial, language, executive functioning, that has some impact on their ability to perform everyday activities, but does not cause this threshold of dementia, so a person can still live independent. But mild cognitive impairment doesn't tell us what the cause is. It's just a description of a person's functioning, just like dementia is a description of a person's functioning. People with mild cognitive impairment may be at increased risk for going on to develop dementia. However, a significant percentage of people with MCI stay at that level of MCI or actually get better. Right now, we don't have any pharmacological treatments for MCI. In large studies, we haven't proven any benefit. One large study with exercise and a number of small studies cumulatively suggest that cognitive engagement are the best things you can do and have been shown to be the most efficacious in improving cognition in people with mild cognitive impairment. So, we get questions now. I'm going to I don't have to repeat the questions, I guess. Who's first? Go ahead.
The key thing that I take away from this is that if you suspect mild cognitive impairment, that you should monitor the rate of decline or whether it stays steady. And that involves doing these psychoneurological tests.
Neurological testing, yeah.
Are there any of those types of tests that are available online for self-monitoring?
Yes, the answer is yes. I don't know the names of but there's certainly a number of self-assessments online. I don't have a strong recommendation in one.
That's what I was looking for.
Our neuropsychologists do that. They leave a pretty big interval between doing the testing. Like the earliest that we test is kind of a year. So the idea of testing yourself like every month doesn't seem.
No. I'm talking about even 1 year separations.
Yeah,
I just didn't know if there were online resources that we could use to monitor.
I know there are. I don't have those off the top of my head.
Is that something that there's a resource here at Ruvo that would be able to give us that list?
Possibly. I'm not sure. I don't know if we have any self-monitoring ones on our website. I'll look into that. I'll let Jasmine know. And she'll pass it on.
But you agree with my thinking that monitoring it
Absolutely.
to see whether it's steady or whether it's declining, particularly with the risk for developing dementia, is an important thing to do.
Absolutely. If we make a diagnosis of mild cognitive impairment, one of the things that we do is monitor people over time. We don't say goodbye, see you in 5 years. We kind of want to monitor them.
And finally, the last follow-up question, to do these neuropsychological tests, is that something where we need to have physician referral to do them?
Yes, you should.
Okay. Community referral or Ruvo physician referral?
Well, you can get it. Primarily neurologists and psychiatrists will make referrals to
And
neuropsychologists.
insurance pays?
Yeah, depends on your insurance.
Exactly.
Yes. Typically, if there's an indication for a neuropsychological testing, yeah. Go ahead.
When you were talking about things like luminosity, doesn't necessarily help. But if you do well on it, or tend to start to do better, then would that change your sense of well-being and cause you to have more interaction with society, so to speak, make you more social? Is that where the benefit could come from?
Well, I think the evidence right now is that any sort of cognitive engagement does help. So luminosity does help. It doesn't seem to be doing anything greater than like reading or doing puzzles or things like that. But yes, I mean, if you can, I mean, there's a strong psychological component to memory performance. So if you're feeling better, I certainly think that the answer would be yes. I think that if you have the means to pay for luminosity and it's something that you enjoy doing, I certainly think that would be something I recommend you do. Because the tests that they develop are actually really interesting and fun. I think they're really kind of neat to do.
What about educational television and or shows like Jeopardy?
So the question was about what about educational TV and Jeopardy? I don't know if there should be a specific study on jeopardy, but things that sort of engage your mind. So we think any sort of engagement where you're not passively consuming television, I think would fall into that category, something that's cognitive engagement that actually is helpful. If you're thinking about the answers to jeopardy rather than Alex's in between how he does the small talk, I think if you're actually thinking about the answers, I think absolutely. Is there another question?
Where does multiple sclerosis fit into the area of MCI?
That's a really good question. We're starting to think that multiple sclerosis always has been thought of as an autoimmune disease. We're starting to think that multiple sclerosis is also a neurodegenerative disease process. It's just not been well recognized and well categorized. We certainly think that MS can certainly lead to MCI, but we just haven't studied these folks that well. We haven't longitudinally followed them. But that's sort of a paradigm shift in the management of MS. Used to be muscular and functional, but it's starting to become a cognitive issue as well. But it's really sort of we're starting scratching the surface on that from that regard. Go ahead. Yes. Sorry.
I don't want to put everybody in the same box, because we have morning people, we've got night people, and you've got shift workers.
Yeah.
So, you have to be.
Right. Well, there's people that disagree with this whole category of MCI. How do you define it? I mean, it seems, ask a patient that say, I'm completely independent, and then the spouse can say, you can't do it, you couldn't do anything. So it's a diagnosis, it's a category that has a lot of critics, but it's something that's kind of been accepted in the literature. And I think the thing about these folks, it's a heterogeneous group of people that have some sort of problem with their cognition, usually memory. But I agree, we should not categorize everybody together. And I think likely if there's like a sleep disorder problem, that seems like something that could potentially be fixed, and those people will be at less of a risk for going on to dementia.
I'm kind of abnormal, but in general, I'm okay. But I'm 71, and the first thing I notice is once in a while I can't bring up the word that I want. And so, what to do?
That seems to be most likely a process of normal aging. Word, okay, so spontaneous word recall or coming up with the right word seems to be part of normal.
I do a lot of the things they say do there, but that's the first thing that I notice on myself.
Yeah, and I wish we could, getting back to this thing about our understanding of the brain is so far behind anything else. I wish we could tell you exactly what the cause is or what the problem is, but we're just not
Is
there.
it the synapses that aren't connecting or something like that?
Yeah, that's potentially the idea, that some of those synapses maybe aren't functioning as well, but most people that have that kind of word recall seems to be part of normal aging, and they don't seem to be at higher risk for going on to develop more problems. We think that's more of a normal part of aging.
Yeah. I don't have a problem with it, but it's the first thing I notice.
Sure.
Say, I'm aging,
Yeah.
I also have the same similar, but eventually I do, but I'm real slow at it.
Yeah.
So eventually I do get the name right, but it's very slow.
The part of, so we think about, we try to, who is normal? I mean, it's hard to categorize. I think the people that don't seem to be at risk for going on to develop dementia are the people that seem slower and having a harder time multitasking and coming up with the right word. That doesn't seem to be that's not a red flag for us in our clinic. That seems to be just kind of, it's part of aging. That's what we think right now. But we don't have any good treatments. We don't really know why it seems to affect other people more than others. We don't know. Put our hands up a little bit, but that seems to be less of a risk.
It's very frustrating.
When frustrating?
Yeah, frustrating.
I imagine. I
All
know
right.
it is. I know it is.
See, you
Go ahead.
already know.
As far as terminology, is MCI and EML the same thing, or is EML a step above MCI?
I'm sorry, EML?
Early memory loss?
That's
As
not
far
a,
as terminology, when you read
Yeah.
about EML and MCI, are they,
I'm not as familiar with the terminology of EML. So I don't know the answer to that. But if you think about, if you sort of fit into that criteria, there's a problem with one of the cognitive domains. It seems to be causing a problem, but it's not to the level of dementia that would fit under the umbrella of MCI. MCI is this big umbrella that grabs a lot of people. That is I think in the next 20 years, as we know more about the brain, it's probably going to go away. We're probably going to say, we used to call this MCI, and we don't do that anymore because it's just a kind of a grab bag category. So I imagine EML would fit into that.
A couple of years ago, the local newspaper, the RJ, ran a story that referenced the LaRue Center here about how in the near future there's going to be, and I came away from the story that there would be like an epidemic of Alzheimer's disease in our society. Is that true or not?
People living longer.
Yeah. So it's interesting. I think, so there's like 50 million people with dementia worldwide. And they think by 2050 that number is going to go to 150 million people. So in the next 30 years it's going to more than triple. But the growth of most of the dementia cases are in the developing world, so places where people are living longer. Unlike MS, where we think that's more related to certain genetic ancestries, Alzheimer's disease, the incidence seems to be equal across the world, so it doesn't seem to be higher in Western civilization or Western society versus Asia or Africa. It seems to be, so that's where the growth of dementia is going to be. I think the idea in the United States is we're better at diagnosing, picking it up, so that might be the idea that we're going to be able to identify people. I mean, 15 years ago, we didn't want anything to do with this population because there's nothing we could do about it. It was almost like, hear no evil, see no evil. But now we want to identify these people, potentially try some treatments, and hopefully develop some treatment. So if we can delay the onset of Alzheimer's disease by 1 year, it would save 9 million cases worldwide. If we could do it by 2 years, it's like 25 million. So we're talking about if we can really just prolong the onset of dementia, we could make a really big difference in worldwide. Go ahead.
We did come a little bit late, and I heard you saying something about dementia and Alzheimer's disease, but I didn't catch what you were saying, like what the difference is.
Sure, yeah. So dementia is a description of a person's functioning. So someone with dementia can't live independently because they can't remember to take their medicines, or they can't remember how to organize food, or how to put together a shopping list, or do those things.
Okay.
It doesn't tell you what the cause is. So there's a bunch of different causes of dementia. Traumatic brain injury being one, brain tumor, something that anything can cause, essentially anything can cause dementia, anything neurologic can cause dementia. Alzheimer's disease is the most common cause of dementia, but you can have Alzheimer's disease and not be demented. So dementia is really kind of like, it's akin to this mild cognitive impairment. It's a description of your functioning, but it doesn't tell you about the cause at all. There's a bunch of different causes of dementia.
So then, when does a person go from mild cognitive impairment to that dementia? I mean, what's the sign of the...
When they can't live independently.
When they can't live independently.
So it's a very subjective call as to when you kind of cross that threshold. So it has a lot of, that's a downside of of what the diagnostic criteria are right now, and that's kind of subjective. So,
Right, thanks.
yeah.
Would we say, is it environmental? What causes?
That's a good question. That's an unanswered question. I think the latest number is it's about 50-50 environment and genetics. So it's kind of like diabetes, so it's multifactorial. So if your parents have diabetes, doesn't mean you're going to necessarily get diabetes. You might be at a higher risk. We still haven't really identified the environmental factors. Traumatic or head trauma, repeated head trauma seems to be a risk factor. High blood pressure, vascular disease, so any problems with your heart or diabetes those seem to be the strongest environmental factors. But we don't know. I think it's about 50-50.
So those of us over 70 should not play professional football or golf or hockey.
Yes.
And don't bang your head on the wall either.
There you go.
If a brain MRI shows lesions on the brain, probably due to MS, would that account for the mild cognitive impairment?
Absolutely. So let's go back to a different picture. So if we look at this part of the brain, so the nuts and bolts part of the brain is the gray matter, so it's the outside parts of the brain. And that's why the brain is folded up on itself, because it increases the amount of surface area devoted to the gray matter. So that, the fact that it's folded up increase. So if you laid out the gray matter, it would increase because it's folded. The white parts of the brain are the connections between the neurons. So, and the connections can go from here all the way down to the tip of our toe, or they can just go from here to here. So think about all the connections. So the white part of the brain is kind of like the wires of the brain. So if in MS, the lesions are typically in the white, or always in the white matter part of the brain. That usually causes the connections from, the efficiency of the brain to go down. So it certainly can cause MCI. It doesn't cause a typical Alzheimer's disease picture where the cortex, the gray part of the brain is gone, so people can't form new memories, but it causes sort of an inefficiency with the connections between the brain. So it kind of comes as a fogginess for a lot of folks, but it certainly can.
And the frontal temporal,
yes.
What happens on that picture with frontal temporal?
Yeah. So in frontal temporal disease, it's instead of amyloid, it's tau, and for whatever reason, the tau seems to be getting into that network that's devoted to kind of, I think about this red part, so the tau gets into the red part of the brain and causes shrinkage of that part of the brain. Alzheimer's disease would be more of the amyloid kind of gets into the green part and causes shrinkage of the memory part of the brain. So it's these proteins kind of get into these specific networks and cause problems. So frontal temporal dementia is kind of a network problem in the front part of the brain. For some reason, tau gets into that front part of the brain and it causes that part of the brain to shrink. So that's why it looks a lot different than Alzheimer's disease. So different symptoms, different neuropsychological performance, different brain scan. So. Well done.